Welcome to the award-winning AUA Leadership and Business Podcast, an official podcast of the American Urological Association. This episode is brought to you by the AUA's Young Urologists Committee.
All right, welcome everybody. I'm Dr. Dudley. I'm one of the pediatric urologists and the section representative to the Young Urologists Committee from New England. And I am really excited to be participating in this podcast. I think it's a really useful and important discussion just to talk about billing documentation and ensuring that we are doing the best job as young urologists. And we are very lucky to have Dr. Chouhan here to help us kick off this discussion. I'll let her introduce herself.
Hi, thank you, Dr. Dudley. My name is Jyoti Chouhan. I am an adult urologist specializing in reconstruction, and I also developed a real interest in coding and documentation. I would say it started in fellowship and really grew and expanded into what is a significant portion of my career currently, which is medical director of our institution's clinical documentation and integrity and our department's director of coding and documentation. So happy to be here today.
Excellent. So maybe I'll kick it off with a few questions and we can follow the discussion from there. But I wanted to first just start with the basics. I think that most of us, when we're starting practice and in training, will identify a few mentors and different resources that will help us with documentation. And there is, of course, the required training that we go through during onboarding. But what are some of the best resources that you have encountered that might be outside of hospital resources and colleagues? Perhaps some books or courses that you may identify as good sources of reliable information for urologists who want to ensure accuracy?
Yeah, no, that's a great question. And I always tell our residents that the onus of really learning billing and coding is on us as physicians, and it can be overwhelming with everything else we just learned in training and then starting a practice to really mature that portion of our knowledge. So the two books I tell them to purchase, and they're not mandatory, and I would say one may be more valuable than the other, but they're both put out by the American Medical Association. And the first one is the yearly AMA CPT coding book, and it has all of the CPTs for every procedure of every specialty. I call it the telephone book. It can be difficult for new urologists to use this book because, like a telephone book, it really just has the code and the name. It doesn't necessarily describe the procedure. For certain things that we do, like let's say a scrotal exploration, it can be hard to know, did I meet the criteria for a scrotal exploration? This type of book won't really give you that type of detail, but can be useful, I think, if you do a lot of work and use codes from other specialties like plastic surgery or abdomen. It gives you some idea of where your work might lie outside of a traditional urology code and help you understand if additional codes could be useful. The second book, I think, that helps you understand what are the components necessary to code for something is a book called the AMA Coding Essentials book, and that divides up the CPT code book into certain groups. And so they have one for urology and nephrology. I can't seem to find one that's been updated since 2022, but I do think if you purchase that version, it does encompass the lion's share of what are current for CPT codes currently. You might miss some new changes in the last few years, but these go CPT by CPT, provide a long paragraph that outline the necessary steps in the procedure to help you understand if that's the work that you did and to ensure that your operative note or your procedure note really reflects those key stages so that you're getting all of the work that all of the credit that you should receive.
Excellent. Well, I think that's super helpful. And I think it brings up some of the thought process when you're thinking about documenting and coding when, as a urologist, you may split your time between the clinic and the operating room, and there could be procedures for both. Is there a pattern of things that you notice in, say, young urologists or trainees when they're thinking about documenting that you would want to kind of have us look out for in terms of making sure that things are done accurately and well?
Yeah, no, this is also really challenging because, like you mentioned, we have clinic considerations and we also have operative considerations with our documentation and therefore the coding. I will start off sort of with clinic considerations. I think if young urologists aren't aware of the insurance guardrails in terms of how to bill based on time and medical decision making, what can happen is we bill based on feel, which can get really, I think, less accurate, and one of two things can happen. So we can overbill where we feel like our complexity was higher than we actually documented, and then our coders will quote unquote downcode that on the back end because the documentation doesn't reflect it. Or we may underbill ourselves, right? We may say, well, that seemed like a pretty straightforward visit and didn't seem too complicated. I probably don't deserve more than, let's say a level 3. And I think that's a mistake too, because how we feel about complexity and how our visit and our documentation meets those coding guidelines can be very different. And if we don't have coders that are as sharp as we would hope, then we might not be able to be getting billed at the highest level that we should. So I think really understanding the guidelines around billing based on time and medical decision making is key. And then I think from an operative standpoint, every group and their coders works differently in how they like to communicate through that documentation to some degree. But I think adding your own CPT codes in your operative note can be valuable. It sort of lets the coders know what you're thinking. And if they're not thinking the same thing, maybe that triggers a communication to you or a re-review to see maybe something that they forgot. I also think where I find we lose credit as surgeons is for our less frequent and or our unusually complex surgeries, i.e. the things we don't do often. So I did a departmental audit a few years ago for our group, and I really felt like that was one of the areas where we were getting undercoded, or parts of the surgeries were not getting coded for because our coders, rightly so, felt uncomfortable and weren't sure necessarily from our documentation what was done. And so instead of reaching out or us reaching out to them, I think RVUs and revenue and credit was being lost. So I think those are just some general points maybe to think about, bring back to your practice, and see where you can improve.
No, I think those are really great points, and some of the things that I've noticed in my evolution in the first few years of practice, definitely trying to be very, thoughtful about what you're including and trying to ensure that what you think is being conveyed matches the guidelines you can find, as well as the billers that you're working with. And then what are some other opportunities you may see for early career urologists in terms of ensuring, that we can bill our worth, be accurate, but also reflects that complexity in terms of particular, maybe like complex clinic visits and or some of these off-label codes?
Yeah, so I think that's always going to be challenging, both for young urologists and also just people who are out in practice, what to do for those two situations. So I'll just take them separately. For really complex cases or less frequent cases, I always reach out to our coders right after the surgery and when I've decided on what my CPT codes are. And I'll say, I did a really unusual case or a really complex case. My codes are in my operative note. Can you take a look at those? Let me know your thoughts before you send it out. It becomes really difficult once coders send the claim out to insurance to try to later on say, well, here's some additional codes we'd also like to ask for. So getting that right the first time before submission is really key. And I think that also helps to build a relationship with your coders where, again, maybe they start to proactively reach out to you and you feel more comfortable reaching out to them with these types of less frequent or more complex cases. Sometimes, urology, we're at the cutting edge of innovation, I'd like to think, and we have procedures that are coming out across all of our specialties that don't necessarily have what we call a category 1 CPT code yet. So a category 1 CPT code is what you find in the books that I referenced earlier. they have been basically deemed a permanent, proven procedure that is worth an assigned value, an RVU. And before you get to potentially a category 1 CPT code, you go through a process of either a temporary category 3 code, or sometimes using what is called an unlisted code if there is no category 3 or category 1 code. So a good example of that might be robotic simple prostatectomy. So before that got its own code, it didn't have a code. And I think people were doing that surgery, and if they were savvy enough to audit their work, they were realizing potentially that they weren't getting credit that maybe was commensurate with the level of work and complexity that they were doing. And so if you reach out to your coders about that situation, they may say, well, there is no code exactly for what you're doing, so we decided to do XYZ. And again, that's an opportunity to reach out to your coders and say, well, if there is no code, how do we assign a value to this that really reflects the work I did? And so what happens is there is something called an unlisted code. There are several of these scattered around the CPT book, and basically using that unlisted code signals to insurance companies that there isn't a category 1 code for this, but it will be linked to a category 1 that as closely resembles the work as possible. And then it's really up to insurance to decide how they are going to interpret that, and what they'll reimburse you for. But there is usually an institutional process for linking an unlisted code to a procedure and a current CPT category 1 code that most closely resembles it. But that type of process really varies from institution to institution. So you'd need to just check with your coding team to see what that's like.
Yeah, no, I think that's super helpful. And I really love how you bring up the, dialogue back and forth with the coders, because I think sometimes depending on their familiarity with your procedures, and even providing different resources to them from what you have, and how you can make sure that you're accurate, because sometimes they may be a general coder, they may be, a substitute, and really trying to have that dialogue in the time before the code is submitted, the claim is submitted, appears to me to be most important. Excellent. And then how about, is there anything else you would tell our new trainees in terms of things to think about, as they're making their way through training? It can be a bit overwhelming. And I remember having a few people who are very focused on billing and trying to pick up, their tips and tricks, but thinking about like a billing eye in terms of going through training, and where you might want to focus some of their educational efforts.
Yeah, I don't know about you, but billing and coding and documentation was nowhere on my radar as a resident. It wasn't anything that was talked about from my attendings, and it also just wasn't anything that even came to mind, I'm embarrassed to say. And I think that there are two sides to that coin. One is our responsibility as attending physicians to try to integrate some of that into the curriculum. I think too much, and appropriately so, we're focused on, surgical technique and handling complications and, making decisions in clinic. But I think we'd be remiss to say that coding and documentation isn't somewhere in the back of our minds as we're doing all of that. So just trying to start some type of didactic series, or, quizzing residents in clinic with you or in the OR. How do you want to build this case? And I do that sometimes, and the residents sometimes like it, sometimes don't, depending on how savvy they are. But I think they appreciate the repetition, and it's impossible for any of us to know everything, and be perfect when it comes to coding and documentation, since it's not a static subject. But I think we could be better as attendings. But from a resident and fellow standpoint, there is some onus on them to ask, right? How did you code that visit? Or how did you learn about, billing and coding? And how long did it take you to become, more facile with this? And do you communicate with your coders, and how? And residents may be reticent to ask that because, again, it's just not part of the culture. But I do think it is something that, for better or worse, is a part of our daily lives and practice as a urologist. And it's only going to make it easier when they start practicing to learn that, when they're training, to your point, or at least have a basic understanding of some of those words and concepts, whereas I totally left, a blank slate from residency and really had a lot of catch up to do. What was your experience?
I would say I think it was mixed. I had one or two people who had a real firm interest and used to talk about, this is why I put this in my note. This is why I think about this because it's pertinent and this will give you credit for this. And then I think, some of my training was at the VA where the documentation and the coding was a little bit different and wasn't really always at the forefront as a trainee. And so I do think that things have changed. And I think that it in the past, perhaps we haven't been focused on the business side of trying to make sure that we're earning, and documenting and making sure that keeps the lights on. And I think that's an important part of medicine, whether we want to admit it or not.
Yeah, no, I totally agree.
And a little bit along that vein, what would you say you think is key when you're thinking about, the first practice? Because I think this is the first time a young urologist might be in a place where they have multiple people that are working, as colleagues at different levels. You have MAs, you have APPs, you have nurses. Are there any thoughts about how to kind of ensure, obviously we want accuracy, but also optimizing kind of opportunities for growth and getting credit for your vision?
Yeah, I really feel like that question had it has nuance in terms of where you're practicing. Are you in private practice? Are you employed? Do you have residents? Do you have APPs? And at what level of the practice are you practicing where revenue and credit from other non-physician sources is important to you? As a young urologist, you might say, I'm just trying to work through my initial contract to get productive enough to meet my productivity goals, and that's about as much responsibility and coding and documentation I can think about. But if you're the head of your practice or a chair, you may be thinking, how do we bill for our nurse work, right? And how do we bill at the top of our scope for our APP work? And I think depending again on your level, documentation and that being your priority can really expand to every person that's touching a patient. And so in our department, we're really working to make sure our nursing documentation is consistent and standardized and reflects all of the work because they do a tremendous amount of direct and indirect care. So wherever we can capture that, we want to. And then in terms of APP support, this also gets a little bit more nuanced in terms of how your practice bills your clinic-based care. Do they bill under the hospital you're working in, or are they billing it as strictly outpatient? And there are differences in that, but I think understanding that nuance and again, trying to build an APP practice that is meaningful for them and accurately captures, the work that they're doing, again, direct and indirect is a must, because more and more, I think APPs are getting paid productivity based, or again, just wanting to support and capture all the work, even if it's not a productivity based practice.
Excellent. And then, in general, what do you think is the best way for urologists to stay up to date on these things? I think, at least at our institution, there are a few billing folks that really push things along via email, and you have to keep your eyes open for changes that can be both helpful and unhelpful. And then comes all the downstream plans of modifying your templates and your workflow and trying to kind of really be cognizant of these things. But what would you think, what have you noticed that helps you stay on top of things?
I think it's so difficult because codes are not only changing within urology, right? They're changing in other specialties. Again, for some of the work that you might do, codes are being added, codes are being adjusted within urology. And then you also have, government influence and CMS influence that affect our ability to do telehealth or create the guidelines and guardrails around clinic-based encounters. So since it's so changes are coming from so many different areas, I still struggle after all these years feeling like I really have my finger on the pulse of all of that. But I do think the AUA Coding Plus series, I do want to plug them, is a really valuable way to get high yield information in a short amount of time. Basically, it's a multi-part series that's done over the course of the year, and depending on what their agenda is, you may or may not feel like it applies to you. But what the new urology CPT codes are, I feel like really helpful. Certain CPT codes and procedures we do that are still causing issues with billing and coders sort of understanding those concepts. One example being PCNL, get explained and re-explained in those courses so that you can bring back that data and reasoning to your coders to work through any issues you might be having in your own practice is a great way to keep up to date. Certainly, some of the regional AUA meetings do a billing and coding course depending on the section that could be useful for you. And if you're already there to enjoy maybe the scenery and the rest of the meeting, it could be nice to check in there. And then oftentimes in hospitals and practices, though not always, there is some type of coding education team who will audit your notes and maybe take a look at 10 clinic notes or a few operative notes and see where where you might have overcoded or maybe downcoded yourself and give you a little bit more insight into what you're doing. And then I think the last thing is auditing your practice, asking your coders or someone within your department to give you, a 3-month log of what you've done and what codes were assigned, and look through those and try to look for inconsistencies. And again, use that as an opportunity to reach out to your coding team and say, sometimes I'm getting this code and other times I'm not. I feel like I'm doing the work consistently. Can we figure out why that's not happening? And maybe you'll realize there's some new change in the code or something that caused that to happen. But those are probably the easiest ways I can think of. It's hard for everyone to do all of those things on top of everything else we do. But any other things that you use that maybe I didn't mention?
Yeah, I mean, I think in general, certainly speaking with colleagues trying to use all of the AUA resources that, are out there. And I think some specialties, I think, are a little more forward thinking about some of the literature that they produce in terms of guidelines. And what I've found is really just trying to find a reliable person that has experience in sort of navigating this, because I do think it really, at each institution, I think it depends on the coders and who's there. We had someone who was gone for a little bit, and then a new person stepped in who was unfamiliar and had to start a little bit almost from scratch. So I think that can be different than perhaps, say, a private practice model where there's someone who's really, neck and neck and perhaps a little more invested at times in your particular practice based on their expertise.
And I think if you have a passion for this and you feel like you could really contribute to changing the department's coding, documentation, and revenue, I think that it's always worth a conversation with your practice manager or your chief to say, is it worth it to fund, a portion of my salary to better improve basically the whole department's coding, through an audit or through taking some of these AUA courses and bringing them back to our faculty and helping to standardize some of our documentation around these surgeries. I wouldn't say it's a common job description in many hospital employed or academic centers, but I think since our department gave me this role, I've really tried to connect our providers with coders when it's necessary, but also be a conduit for rare and complex cases to make sure those are getting coded appropriately, in addition to, doing department audits and seeing where we're potentially having providers consistently upcoding or downcoding and working with them to improve, our consistency and our accuracy.
No, I think those are all excellent points. And I think, again, the theme I'm hearing over and over and over again is just, continue to advocate for kind of what you did. Make sure that you're trying to look for resources that can accurately reflect that. And I think that will pay off in the long run. Excellent. Well, I think that was it in terms of the questions that I had come up with. Is there anything else that you think that would be helpful? Anything you wish you had done earlier on that, we haven't touched on?
I will plug that the AUA transition manual really for a lot of concepts, not just billing and coding, but I think there are a lot of considerations when you become a young new urologist other than taking care of patients. And I think that manual does a really good job of at least causing you to pause and think about these other areas in which our practice are very important, but maybe not as directly patient care oriented. The billing and coding section, I think, is a nice way to start and have some of those thoughts organized, along with a lot of the resources we've talked about today. But the AUA does a really nice job of trying to promote a lot of these types of business and leadership topics in a wide variety of ways. So just wanted to mention the manual also.
Excellent. Well, I really appreciate you taking the time to meet with us, and I will also highlight all of the content from the Young Urologist Forum. I think we've had some great chairs in the last few years and very pertinent discussions. So I really enjoyed participating in that and hearing your thoughts about this.
Thank you so much.
Awesome. Thanks, guys.
Make AUA Leadership in Business your go-to podcast. Subscribe today by searching Leadership in Business on your favorite podcast app and enhance your leadership and business education needs. Until next time, continue to learn, lead, and excel.